All right, so I'm going to be talking about nursing management of the oncology patient. So let me share my screen so you can see what's going on. And here we are. So there are some different implications associated with all of the different interdisciplinary treatments that I just made. So there are really common side effects associated with oncology treatment. Bone marrow suppression, which I talked about. Because these people are getting a lot of different therapies that are really hard on the body, they're going to be they're tired. It takes a lot to go through cancer treatment. Chemotherapy and other therapies can create GI problems. There's integumentary and mucosal reactions. There can be pulmonary effects, so our heart, lungs, and then there's reproductive effects as well. We have a huge role in helping people deal with the side effects of chemotherapy and radiation. So educating clients about their treatment regimen, any supportive care options such as antiemetics and antidiarrheals, what to expect during the course of treatment, we're helping them decrease their fear and anxiety. We're encouraging treatment plan adherence, and then we're also helping them guide themselves through self-management at home. Before we really begin this huge educational effort, we do have to understand and assess their ability to process information and then customize that teaching to meet the patient's and the family's learning needs. We're also going to be using interventions to counteract the effects of myelosuppression and thrombocytopenia. Anemia is a very real possibility here. Nausea, vomiting, anorexia, not necessarily anorexia nervosa, but legit anorexia. I have GI distress, I'm not eating. Stomatitis, diarrhea, constipation, mucositis, and skin reactions are all sorts of areas that we may need to intervene and help educate the client about how to manage. For bone marrow suppression, there is a couple different things that we need to be aware of. So myelosuppression is the most common side effect of chemotherapy, just putting it out there. And the major difference in manifestations between radiation and chemotherapy is that with radiation, which is a local therapy, only the bone marrow within the treatment field will be affected. Whereas with chemotherapy, which is a system-wide intervention, it affects the bone marrow function throughout the body. So we need to understand that the onset of bone marrow suppression is related to the lifespan of the type of cells. So if a person is getting chemotherapy, white blood cells only have a lifespan of about 1 to 2 weeks. Your platelets live about 2 to 3 weeks, and your RBCs live about 3 weeks. So if we're having these bouts of chemo that are lasting a week or 2 or 3 weeks, we could really have significant reductions in RBCs, WBCs, and platelets. So one of the more common side effects of chemotherapy is neutropenia. And neutropenia is a lack of the ability for a client to fight off infection. We will talk more about that when we talk about hematology, but just so that you're aware, neutropenia completely cancels out a person's ability to fight off infection. They will also bleed easily, and they will have overwhelming fatigue because they don't have any RBCs to be able to carry any oxygen around. Fatigue, some of the different implications that we can have for fatigue is to really encourage conservation strategies. And fatigue is universal. And most every patient that has is fighting cancer is also fighting fatigue. It's commonly reported as the most distressful of the treatment-related side effects, and it can last a lot longer after treatment has ended. So there may be some really long-term, and I don't think anybody really expects to be as wiped out as they are. One of the reasons why they have all of this fatigue is from anemia. Other causes might be from the toxic substances that are left in the body after cells are killed by the cancer treatment. So once the cells are obliterated, all of those bits and pieces have to be filtered and processed and removed by the body. It's very common for people who are on chemotherapy to also be on allopurinol. Allopurinol is usually for gout and for uric acid. However, uric acid is a byproduct of all of this cancer cell destruction too. So they won't have gout, but they will be on allopurinol simply to help body process all of that uric acid that's released from the cancer cells being destroyed. Another cause is just all of the extra energy that's needed by the body to repair and heal body tissue damaged by the treatment. And then some of those chemo drugs, because of the severe nausea and vomiting and diarrhea, they just don't sleep. So then they're just wiped out still from that lack of sleep caused by some of the chemotherapy drugs. Some of the more helpful tools that we can help people use or encourage people to use is resting before activities, getting assistance with activities, maintaining or remaining active during periods of time when people feel better. We can help them maintain their nutritional and hydrational status as best we can. And then maintaining an exercise routine or an activity routine that's within tolerable limits is also really helpful in managing fatigue as well. As far as the GI effects, there are different tools that we have available from pharmacy and from the medical team prescribing things. So we can have prophylactic administration of antiemetics. A lot of these people will have Zofran right along with all of their different other medications that they can take at home. We will be assessing for signs and symptoms of alkalosis and dehydration. Remember, all those awful GI effects from the chemotherapy and from the radiation therapy really can create an acid-base imbalance and dehydration. So we'll be monitoring their INO a great deal. We can help them figure out a non-irritating, low-fiber, high-calorie, high-protein diet. How do we, what sort of protein shakes they don't, we can do all sorts of different nutritional supplements. We can help with anti-diarrheal, anti-motility, anti-spasmodic, or spasmodic medications, such as, hi, I'm recording. Oh, that's okay. Hi, Marguerite. Don't worry. You're in my cancer slide. No. I get from Marguerite. All right. So anyway, surprise. That might be something we talk about in class. Anyway, so non-irritating, low-fiber, high-calorie, high-protein diets, anti-diarrheals, a little Imodium, a little Pepto might be a very appropriate intervention for these people. And then anorexia. I remember my husband went through cancer, and he said that there were times where he just didn't want to eat at all. He just was so tired. It took too much energy for him to ambulate into the kitchen to grab his, because he had a peg tube, to grab his tube feeding and set it up. Like, that was just beyond what he could tolerate in terms of activity. So he had anorexia for that reason. So we're going to be monitoring people carefully about and teaching them how to avoid weight loss, how to track their weight, how to get in enough calories and enough protein. And sometimes we're just bringing in registered dietitian, nutrition therapists, like right away, to be able to help these people figure out what is going to be great for them before they get into a nutritional crisis, rather than try and fix the problem once. If we can divert the problem in the first place, so much better than actually just waiting until if it becomes a problem, because it's usually not if, but when it becomes a problem. Okay. Let's see here. Oh, many Christmas. I keep doing that too, and I'm sorry. So let's talk about nursing implications. So there are some more nursing implications, actually. So there can be some really bad skin reactions to the radiation treatment field. Remember that the radiation treatment, we have them in a very specific spot. We can even have tattoos to be able to make sure that they're in the right spot. But that doesn't mean that the skin that we're taking that radiation beam through isn't going to be damaged. So there is a possibility for acute and for chronic problems with their skin that's in between the radiation delivery mechanism and the target area. So the nice part is the radiation problems will only be for that localized treatment. They can be acute or chronic, depending upon the area that's getting the radiation, the dosage, and the technique. Skin folds are highly susceptible to skin reactions, or anywhere the skin is subjected to pressure. So like if for whatever reason they can, it's really easy for them to get skin damage behind the ear, in their gluteal fold, their perineum, their breast, their collar line, bony prominences, just to let you know. So let's see here. And then there are some different effects as well for pulmonary and for cardiovascular. So people can develop coughs, shortness of breath or difficulty breathing, pneumonitis, which is an inflammation of the lungs, and pulmonary edema. Pulmonary edema is where there's too much fluid around the lungs. But we can treat those with bronchodilators, with expectorants and cough suppressants, bed rest, and helping them get again, this goes along with fatigue, where we can help them cluster their activities and perhaps rest up, as well as providing some supplemental oxygen. Both chemotherapy and radiation do have the potential to produce pulmonary tissue damage. That damage could be irreversible and it could progress. So we really do need to be aware of the difference between the complications of treatment and those related to the disease. But that can be challenging too. There also can be immediate pulmonary effects of radiation, and those can be really alarming to clients because they can mimic symptoms. Like, let's say somebody's getting a treatment for a lung cancer, and then they're getting this they're having these cough and that's difficulty breathing. That's the whole reason they came in the first place, and now they're getting chemotherapy and radiation, and it's making it come back or be worse. What? And so there's a lot of education that comes along with this about how that is not necessarily like the cancer isn't getting worse. It's just that the treatment happens to be causing the same problems that the cancer is causing, which is hard. It's a little bit mind-blowing. And so even just for me, and I'm sure it is for you too, so then that way we can see where clients would get really confused about that. Pneumonitis, pulmonary fibrosis, pulmonary edema, hypersensitivity pneumonitis, interstitial fibrosis, and pneumonitis produced by an inflammatory reaction or destruction of alveolar capillary endothelium are all possible. So the other thing about this is chemo and radiation can also produce irreversible and progressive cardiac toxicities, that cardiac muscle is also a rapidly dividing cell. It maybe isn't as rapidly dividing as like a hair follicle or as your GI lining, but it is a rapidly dividing cell. And so you can have problems with cardiac toxicity as well. Pericardial effusions can be common, where you have inflammation that causes fluid build up between the pericardial sac and the heart, and it creates pressure on that extra fluid, creates pressure on the heart and limits the ability of the heart muscles to contract because there's just not enough space. We can use different sorts of medications to be able to help that, but we really do need to monitor for cardiac abnormalities through EKGs. You'll learn about that in term 3. We can, and then signs and symptoms of left ventricular dysfunction and heart failure. So if we're having different problems with like left ventricular failure has some very specific sorts of signs and symptoms that you'll talk about when it comes to heart failure later on in the semester, just to let you know. There are also going to be periodic echocardiograms to monitor that left ventricular function during treatment. An echocardiogram is an ultrasound that's done to be able to take a look at heart function. There are also cognitive effects of cancer treatment. And they can happen anytime during the cancer, especially after treatment. So chemobrain is an alteration in mental function, and it's described by patients as like mental cloudiness or like a brain fog. Patients experience thinking and memory problems. The brain will recover over time, but the effects can last either a short time, but sometimes they can last for years. And this effects may be so severe that the clients may not be able to participate in activities that require a lot of mental effort. So it may require them taking a leave from school or a leave from work. Maybe they have to change jobs, or they may have different social activities change too, just because of their cognitive effects. If they're an avid chess player, they might have to move to checkers or some other social activities to be able to, because the mental stimulation involved with their social activity is just too much. There are, as far as reproductive effects, we will be informing the client of expected reproductive side effects. So we'll also be trying to use as much appropriate shielding as we possibly can. We'll be encouraging the discussion of issues related to reproduction and sexuality. We'll be referring to them to counseling if needed. One of my really good friends from elementary school developed cervical cancer, and what her and her treatment team did prior to treatment is they actually did, they froze some of her eggs. And then after she was treated and cancer-free, I think for like 3 or 4 years, then she went through and became pregnant and has like 2 kids, and they're amazingly smart, sarcastic little people like she is too. So like but that was something that needed to, that was a discussion that needed to happen far before she ever started treatment, so that she could actually have some eggs available for having kids at a later time. Let's see. There are also some late effects of radiation and chemotherapy, and most of it's because, especially the people who get like the alkylating agents and high dose radiation. It could be progressive. Generally, it's permanent. And for all the good that we tried to do with the chemotherapy and the radiation, we may end up causing a secondary cancer. So radiation therapy, chemotherapy can produce long-term consequences months to years after the cessation of the therapy that affect every system. So late effects of radiation therapy are commonly found in like liver, kidney, lung, heart, muscle, bone, and connective tissues. So it could be like skin strictures, it could be fistula. It also could be like alterations of the lymphatic channels that would create lymphedema. So there's a variety of different lymphedema sleeves or TED hose that people can wear to be able to have that lymph returned back up into the system as a long-term side effect of chemotherapy and radiation, or of radiation rather. For chemotherapy, it's really common for people who have gotten like high dose chemo to have cardiac problems later. The chemotherapy damages the cardiac muscle, and so they may have reduced ejection fraction, which is a measurement of how well the cardiac or the ventricles squeeze. They can also have cataracts, endocrine alterations. They may have renal insufficiencies. They may have kidney problems, hepatitis, liver inflammation, osteoporosis, weak bones, neurocognitive dysfunction, that brain fog that we were just talking about. And then if there was a multi-agent chemotherapy, along with radiation, like if we're really just going at the chemo or the cancer with everything we've got, that the more interventions we have to do, the more increased likelihood there is of late effects later. There is also, we also need to be aware of that secondary cancer risk does not contraindicate the use of a cancer treatment. So we may be in a position where we have the client getting a chemotherapy radiation combo situation that the team is aware that they may develop a secondary cancer because of this. But the primary cancer is such that it's going to take them, if we don't hit them with everything we have available, they're going to not be able to meet their, well, it's not going to be, their cancer is incompatible with life, basically. And so we need to be able to have that strong onslaught of everything we've got, and we can deal with a secondary cancer when that becomes a problem. And that will kind of become almost the way of thinking, is we got to take care of the primary cancer, and if a secondary thing happens, we'll take care of it at that time. But for right now, we really need to focus on the actual problem rather than not fix the actual problem or back off on fixing the actual problem in hopes that we don't cause a secondary problem. The philosophy is we got to take care of business. We're taking care of the primary problem. And if something comes up later, we'll take care of it then. I'm going to stop sharing there. That is nursing interventions and treatments for oncology. Thanks for paying attention. By the way, the guest appearance made earlier today was by Dr. Marguerite Doomer. And so if for whatever reason I happen to perhaps come to class and say there's a prize, if you can tell me who made a guest appearance in my video, that's the name you're gonna want to remember.